live presentation. So very good. Thank you, Isaias. All right. Well, we've got a great group. For all of you who just joined and are attending the presentation today, if you are able, I would love it for you to turn on your cameras. I will tell you as a presenter, it is so much more fun to see your beautiful faces as we're presenting. So I really, really encourage you to do that. You're going to be impressed with this panel today. We've got a very distinguished panel put together today to talk about maternal and child health outcomes as part of our 20th anniversary speaker series. So I'll go ahead and formally welcome everyone. Again, I encourage everyone to turn on their cameras so that we can see you and talk with you. Dr. Valerio-Shewmaker, if you'll lay out how you want to handle questions when I introduce you, just so they know whether to chat them or hold them or whatever. So we're very excited about today. So today is it's a special speaker series that we've put together to celebrate the UTHealth School of Public Health Brownsville's 20th anniversary. So there's been 20 years that we have been in the Rio Grande Valley, serving the Rio Grande Valley, and we determined at the beginning of this 20th year that the whole year we were going to celebrate. And we were going to look at different ways that we could share about information and research and approaches that the campus and our partners have been doing together to make a difference in public health. And I think today's presentation is just the quintessential example of that. It's a wonderful study with a panel of experts from across the area who have been focused on maternal and child health. So I'm not going to steal any thunder here. My job is to welcome you and then to introduce to you someone that most every one of you knows, Dr. Melissa Valerio-Shewmaker. She is the Associate Dean of Faculty Affairs, Development, and Diversity, and an associate professor with tenure in the Health Promotion and Behavioral Sciences Department at the UTHealth School of Public Health, and she's based right here in Brownsville. Dr. Valerio's interests include chronic disease management and prevention, the design and evaluation of effective health education messages and materials, and survey methods. She has been involved in the planning, implementation, and evaluation of community-based coalitions and partnerships. And most recently, she served as a PI on studies focused on the design and evaluation of innovative functional health literacy, related interventions and strategies to promote disease management and prevention. And we're so fortunate that today she'll be speaking about maternal and child health outcomes, as we know this is something that's so important in the Rio Grande Valley. And I've asked that Dr. Valerio-Shewmaker introduce her distinguished panel, but I want to give a special welcome to each and every one of them. Thank you so much for taking time to speak with us. So Dr. Valerio-Shewmaker, I turn it over to you.
Thank you, Dr. Reininger, and thank you for the invitation to all of us as a panel. We've been working together for over 5 years now, Divya? Yes. And I see Ms. Gomez also, Sylvia Gomez, and I think Blint, I always forget the Blint. And I thank you. As partners, we've been working to address maternal and child health outcomes in the Rio Grande Valley, specifically in Hidalgo County. And we have 3 additional partners in this work. So they are our partners in crime. And we want to emphasize the process, how we worked as a community academic partnership in this work. And the first speaker will be Dr. Divya Patel. And Dr. Patel is an associate professor with UTHealth Science Center at Tyler and affiliate of the University of Texas System. She is the lead for the Texas Collaborative for Healthy Mothers and Babies, and she is an epidemiologist, graduated from same alum. She's Go Blue, University of Michigan, with a broad interest in women's health research. She has also worked at the Texas Department of State Health Services and at the Center for Disease Control and Prevention on population level maternal and child health projects. And she also holds an adjunct position with the UTHealth School of Public Health Austin Regional Campus. We also have Ms. Gabby Calzada, and Gabby is a registered nurse with 12 years of experience and has been with Nurse Family Partnership, the program, since 2012 as a nurse home visitor. She has worked with underserved clients and their families in Hidalgo County and across the Rio Grande Valley to provide services and community resources. And she is currently transitioning to the new NFP nurse supervisor role to provide continued support to her team and the families they serve. And our fourth speaker is Mr. Jesus Peña. And Jesus, I love that he started this way. So Jesus has been married to his beautiful wife, Evie Marie Peña, for 14 years. And he is father to Jessica Marie Peña, 11 years, and Jaden Marie Peña, 10 years old. And Mr. Peña has a master's degree in educational administration and a bachelor's in science degree in mathematics. And he is passionate about serving fathers in the Rio Grande Valley and beyond. He is founder of RGV Dads, which started serving Hidalgo in the RGV and now is extending across Texas as well, their reach, in July of 2019, and they will be celebrating 3 years of service to the community next month. So thank you also for joining us while on vacation, and we really appreciate that. So we will have Dr. Patel start first, and I will begin sharing these slides. So again, thank you everyone for joining.
All right, well, while Melissa gets the slides going, I wanted to thank you all for the chance to speak and share today. It's a great opportunity to share on some work that's been happening in the community, and really happy that I got to work with this amazing team. As part of the project, I just wanted to say that I got the chance to come down to the Valley several times, and I think it's an amazing place. I've never met friendlier people, more welcoming, and I'm very lucky to have visited a part and worked in a part that I don't think I ever would have gotten the chance otherwise. So healthy families, and I'm going to share a little bit about the background and the framework of the project. So Melissa, it looks like you have the slides up. And okay, so like Melissa said, I'm located in Austin at UT System Population Health, and as part of that work, we were invited to participate in a project related to, it was very, very unique because this was a project that was a partnership between a Texas state agency, community partners, and academic institutions. And this was a project that the whole goal was to understand how we can take evidence-based interventions and identify things that work and really help to adapt them to the context of the community and then implement them. And the whole goal was to address priorities that were identified within the community with the overall hope of reducing disparities in pregnancy-related outcomes and birth outcomes. So just to give you a little bit of background, this was a project that was funded by the Texas Health and Human Services Commission. It was a 4-year initiative. So we started back in 2016, and they selected 2 counties of interest for the project. One of them, Hidalgo County, was selected because of generally lower use of prenatal care. And so they wanted to understand what were ideas and interventions that could be used to make sure that moms were getting into prenatal care early, on time, and getting the number of visits that they needed. So that was one of the reasons why Hidalgo County was selected. The other county was Smith County, which is very different population. We were targeting for the project African-American moms in that region because of the very long-standing disparities, health disparities, as well as deep-rooted disparities in infant mortality in that part of the state. And so those were the two regions. And so the whole goal was to work with communities. It was very much a community engaged partnership so that we could learn and see what could work and then develop interventions. And so what we're showing is this was sort of the overall model that we developed or the framework for this project. So you can see what we wanted to highlight here was that women in the community are very much at the center of our model. And that was what we always try to keep in mind, that we're trying to help serve women in the community and make outcomes better for women in the community. So like I mentioned, we had academic partners at our two sites. So in Hidalgo County, we worked very closely with UTRGV School of Medicine. So we partnered with the Department of Pediatrics and the Department of Obstetrics and Gynecology. And then in Smith County, we also had a partner, an academic partner, which was the UTHealth Science Center at Tyler. Our partner, where sort of at the bottom of this diagram, it says we had a partner in San Antonio. Well, that's now your beloved Melissa Valerio-Shewmaker. She was our partner at San Antonio at the time. She was very much responsible for the ongoing evaluation throughout the duration of the project. So she's a very important partner on the project. And so really this model was developed from the ground up. And so a lot of it was evolving, but the main focus was that we wanted to have this very data-driven and used so that we could identify what factors in the community were influencing infant mortality and maternal morbidity. And how we did that, and Melissa is going to go in more depth, but we had many different points of contact with the community. So we did a series of focus groups where we really had conversations with pregnant moms. We had conversations with dads, conversations with clinicians and partners in the community, physicians, nurses. We convened regular stakeholder meetings with various members of the community so that we could hear and get input. We could share on the project, and then we could also hear back to see, is what we're seeing what you're thinking and what you're seeing in your community, just to make sure that we were always kind of on the same page. We also had access to a lot of data through this project, which was really important. So we looked at birth certificates, death certificates, Medicaid data, hospital discharge, so large data sets that could help inform us of the ongoing needs in the community. But really, at the heart of it was, how could we build that community capacity so that we could link pregnant women with the resources that are available and existing in the community. So that was really the focus of this model. And through this project, we were able to develop a lot of new partnerships within the community and with clinical partners. And the whole goal was better linkages for women in the community to services, not just health services, but other types of services that would be available and resources in the community. Next slide, please. So to share a little bit about the evaluation, this was an ongoing part of the project that was very much baked into how we proceeded through the 4 years. So we wanted to make sure that the programs that we were either working to adapt or the new programs that we were developing as part of the project were going to meet the needs of women in the community. So you'll see that kind of at the center of the circle. And so that was always our focus. And to do that, we realized it was going to be really important to have that community voice piece, just again, very much integral to the model. So we had, like I mentioned, the stakeholder meetings that we would meet almost every quarter to share data and get more input. We had the focus groups that I mentioned, and we also Melissa did one-on-one interviews with many key players in the community to understand perspectives kind of at an individual level. We also use the data that I mentioned with the large data sets to understand what are the socioeconomic characteristics, what does it look like in terms of prenatal care, pregnancy-related care in the region, And then other risk factors that we know are really important to maternal and infant outcomes. So we use that data that we had to really inform the project over the course of the 4 years. And then what we did was we also looked into the literature to say, okay, based on what we're seeing, what are some opportunities here? What are some gaps? What are some needs? What are existing partnerships and programs? Are there other things that we might be able to consider that we could work on implementing in the community? So on the left side of the circle, you'll see some of the programs that we helped to adapt or develop over the course of the 4 years. So community health workers very much in existence in the region already, but we worked more closely with the CHWs to see about ongoing education needs that they felt they needed to help them get more on board, specifically with the needs of pregnant moms. We worked with the home visiting program, so nurse family partnership, which Gabby is going to share about. We helped develop a mobile clinic model that could help serve women in harder to reach areas. And I'll talk about that at the end. That's still ongoing and has been further expanded after Healthy Families ended. Lifestyle medicine, so incorporating a holistic approach to clinical care. And then one very important part was the health equity training for our clinical partners to make sure that the important aspects of health equity were being taught, so that when people in the community, clinicians, were interacting with their patients, they had that perspective and understanding. And so Melissa will talk a little bit more about some of the qualitative, the focus groups, and other things that we did. What I wanted to show, and Melissa, if you go on to the next slide, I wanted to just give some examples of the types of data that we were sharing with our partners at every opportunity when we would have the stakeholder meetings. These were the types of things that we were sharing. So we're going to go through a series of slides, and some of this may be very familiar to you. You might have seen it in our stakeholder meetings or through other sources. But it was interesting when we would share the data that people would come up after and say, and they would say, "Thank you so much. This was something that we knew intuitively, but it's really good and important to see the numbers and to see the data." And so this is one of the examples that we showed early on. This is the infant mortality rate. So the deaths to infants for every live birth. And so this is just a rate that's pretty standard. But what we wanted to make the point is that if you look at Hidalgo County across the board overall, actually we're doing better than the state. So the rate generally is 4.5 per 100,000 live births compared to Texas, which is 5.4. So if you just look simply at the county level, you'd say, oh, okay, we're doing fine here. We're doing better than the state. But when we dug more into the numbers and we looked more granularly at a smaller level, so we had access to the data where we could dig down all the way to the zip code level. So we were finding zip codes in the county that had much higher infant mortality rates, even as high as upwards of 8 per 100 or per 1,000 live births. So we highlighted in this map a couple of areas. The darker areas are the ones that had the higher rates, and you can see ones like 78516 Alamo, Elsa, San Juan. Those were areas that had substantially higher than the overall rates. So what we did was we used these data to kind of build the case that there are regions within the bigger county that might need targeted outreach and more assistance, more technical assistance, more resources put in. And Melissa, if you don't mind moving on. Because one of the major emphasis of our Healthy Families was to look at prenatal care, we wanted to start with the basics. What about the proportion of women who went through their whole pregnancy without any prenatal care? Well, again, if we look at Hidalgo County as a whole, we can see that overall, it's better than the state. Only 4.7% of pregnant moms didn't have any pregnancy-related care, compared to 5.1% of women in Texas. But when we dug deeper and we looked at the zip code level, you can notice a couple of really of counties that are zip codes that stand out in the dark red or dark orange. So South McAllen, those couple of zip codes, Far, Alamo, those were much higher than 6% of pregnant moms that were not having any prenatal care. Melissa, please advance. We also wanted to look at, for those who were getting prenatal care, were they getting what we consider adequate prenatal care? And that's based on, there's an index that looks at the timing. So when the mom gets her first visit, how many visits she gets over the course of her pregnancy. So the Healthy People 2020 target is that at least 77.6% of moms get adequate prenatal care. And when we broke it down for Hidalgo County overall, we saw that it was only about 70% that were getting adequate prenatal care. And it was much lower once we looked at other characteristics like maternal age. So you can see how the youngest moms were the fewest proportion of that those women were having at what we would consider adequate prenatal care. So clearly some patterns with age, with the younger moms maybe needing some more targeted outreach. Next slide, please. And these examples are just to show you and highlight the types of data that we were showing when we would go to our stakeholder meetings. This is one that I thought was really interesting and informative for our project. This is the cesarean delivery rate. So clearly some disparities here, where in the United States, we have about a 32% C-section rate. In Texas, it's slightly higher. But if you see South Texas, Hidalgo County, it's substantially higher than the US and even compared to Texas. The data sources that we have access to were very mixed. We used some published data that the state health department puts out, and then we analyzed our own county level data to look more granularly. Next slide, please. I had mentioned that we, aside from maternal morbidity and mortality and infant mortality, we also wanted to look at what are risk factors in the region that could be explaining some of the negative birth outcomes and pregnancy outcomes that we're seeing. One of the big things that we noted was that there's a lot of variation in pre-pregnancy obesity in the region. So you can see that Hidalgo County has a higher proportion overall of moms that were obese prior to their pregnancy, so 27% compared to 23% in Texas. But if you look at some of the smaller levels within the county, so there you can see that there are several areas where upwards of 40% or more of moms were obese prior to going into their pregnancy. So pregnancy-related obesity is an important issue because that is a risk factor for so many other things, including low birth weight, preterm delivery, even C-section. And so these are just important indicators of maternal health. And then of course we can't break away the infant from the mom. So these are important indicators of infant health as well. Next slide, please. We also, and this was on Melissa's request actually, and I'm really glad she suggested that we look at some of these measures broken down by whether the mom was a first-time mom or had multiple children already, maternal age, and we did notice some patterns. We noticed that pre-pregnancy obesity was a lot higher in the older moms compared to what it looks like for the state as a whole. So some opportunities for improvement and looking at ways to improve pre-pregnancy obesity, especially for the older moms. Next slide, please. And so I'm just going to introduce this idea, and the rest of the speakers will be highlighting definitely the Nurse-Family Partnership and the RGV Dads. But just wanted to mention that the work that we did, like I said before, was not. We didn't want to imply that there wasn't a lot of work already going on in the region. There's lots of things that are happening. Our goal was just to see whether there were additional opportunities to either expand current services or opportunities to build new things, new partnerships. So these are a couple of the things that we worked on in the course of the 4 years. So the mobile clinic, which I'll show in a minute, and that was a way to engage women, particularly in the harder to reach areas, like in the colonias, where there might be very little access and trust with the medical system. So how can we provide needed services in those regions to those vulnerable women? So we developed a mobile van model that would help provide contraception, prenatal care, and screening, and with a way to link women for their additional care into more established clinical settings. And we usually, we always tried to look at what areas of the county needed more, and we would actually park the van in those zip codes. And so we use that secondary data to target our placement of where the van would be for services. We also worked really closely with RGV School of Medicine Pediatrics to develop the group pediatric care model where moms and dads would come together in groups, and they would have kids of the same age, and they could do their pediatric care in groups so that they could share resources, use that support of other parents that are going through similar things. So we worked on developing the group model for pediatric care. We also worked with the community health, the promotoras that were already in the region. They were really helpful in showing us how we could start to track the services that they were linking moms with. So they were the ones that helped us develop a tracking service to make sure that women that were getting referred to services were actually connecting and linking with those services in the community. And then Jesus is going to talk a lot about the fathering education and engagement aspect that was seen as a really important part of what we learned from our focus groups and other data. Next slide, please. I just wanted to end my presentation with something that I'm really proud of and really excited about. This is the mobile van Healthy Mujeres Unimobile program that's in the Rio Grande Valley. And this is a labor of love, I would say. This is something that started several years back at the start of the Healthy Families, where we were noting, like I mentioned, that there are communities that were having very low access to care, but definitely still needed care. And so we worked with UTRGV to use the existing van that is already there to then repurpose it to go out in the community and provide needed prenatal and other services to women in the communities. So this is a very dedicated project team of Dr. Saul Rivas and Dr. Tony Ogburn, and then many partners that we've been lucky to work with. Angela Tanguma, who was one of our nurse practitioners on the team and is now basically helping run the clinic along with her other clinical collaborators. We have a team of community health workers, a medical assistant, Diana Lopez, and then we have other investigators that are working with us on the data side of it. And then myself, and we have a few of us at UT System, and this has been funded after Healthy Families ended. The Texas Health and Human Services Commission was really pleased with the work and wanted to fund for an additional year. And we just heard that the project is actually going to be funded for another year starting this September. So we're really lucky and fortunate to get with this team. But I just wanted to mention that just in the last year, thank you, Maria, that was a nice clap. Just wanted to mention in the last, it's only been 8 months of the project, this Healthy Mujeres project. We've already been able to provide contraception services to 361 women, pregnancy-related services to 556 women, referral to other care. So we have women that have needs with hypertension, so high blood pressure, diabetes, all kinds of things. We are able to help link to routine and ongoing care. Education, important, provided by the community health workers to over 1,000 women. And then we're also working to help women link to available health insurance programs. So whether they're eligible for Medicaid for pregnant women or CHIP perinatal, Healthy Texas Women, just trying to make sure that any available option for them, they're being linked into so that they can have coverage for their ongoing medical needs. And so I just wanted to end on that. I'm again, really grateful for the opportunity to come and share about the work. This is an amazing team that I got to be connected with. I've made lots of really close friends through the project and really love working with all of you. I think next I'm going to turn it over to Gabby to share on the Nurse Family Partnership. So thanks everyone. I'm always available for questions. I think the next slide has, I'll just skip that. I think I talked, but next slide has my contact, and
we'll take questions at the end of the presentations, and that we can come back to specific slides as needed as well.
Sure.
Gabby?
All right. Thank you, Dr. Patel.
Thank you.
Hi, everyone. It's a pleasure being here and to talk to you about the Nurse Family Partnership Program. Although there's so much data and information on all the successes NFP has accomplished for clients in the community, I'm going to stay in my comfort zone and do something a little different and present through a nurse home visitor's perspective. and what those visits entail. And if there's any additional info anyone would like, you can contact me and our team can definitely provide that for you. All right, so you can see our team presented here on the slide. Next slide, please. So first of all, qualifications for clients to be eligible for the program is first and foremost being a first-time mom, less than 28 weeks gestation, and low income, which is below the 185% poverty level, as per WIC guidelines as well. Another point I'd like to add, because it's a question that we've been asked sometimes, is the client can be of any age as long as she meets the criteria. We've had a range of 12 to 45-year-olds in our program. Next slide, please. The main program focus is the statement you see right here. The nurse home visitor helps to empower first-time moms to transform their lives and create better futures for themselves and their babies. Oh, sorry, last slide. And to get there, the following slides entail some of the specifics nurse home visitors do throughout each of their visits with their clients. Another point I'd like to add is a crucial skill for a nurse onboarding with NFP is having a non-judgmental perception and maintaining open-mindedness in order to establish rapport and begin building that trusting relationship with the client. Next slide. At our site, located at DHR Women's Hospital, we have 7 nurses on our team. Each nurse carries a caseload of 25 to 28 clients. Our capacity goal is 175 to 196. And in the past year and a half, we've been able to reach our minimal goal of 175 clients, and there's still room for growth. These clients are carried throughout a 2.5-year program time span, or from pregnancy through the child's 2nd birthday. Next slide. Most of our clients find out about the Nurse Family Partnership Program through referral sources such as WIC clinics, healthcare providers, schools via social workers and nurses, other NFP clients, and self-referrals through advertisements and social media. They'll usually reach out to us when they hear about our program and become a self-referral. Also, we've had transfers from other NFP sites within Texas or other states. We recently had a transfer from Colorado. And some referral strategies that we try to adhere to are done through community outreach, leaving brochures at OB offices, and participating in community events. Next slide. We currently serve Hidalgo and Willacy counties. The majority of our clients are Hispanic and bilingual. There's a small percentage who solely are Spanish speaking. Initially, most clients fall below the $6,000 annual income bracket and are dependent on their parent or guardian. It's common that most clients consider themselves single, never married, but do live with or have a close relationship with the father of the child. And although some clients have not completed high school, most do have a plan to enroll or continue their education, whether it's GED or college. And most of those goals, the nurse home visitors continually support and encouraging clients to achieve. All right, next slide. So these are our program benchmarks. These are done routinely at what we call time points, which are data assessments that are completed and capture the following. Babies will be delivered at full term. Women will initiate breastfeeding and continue until the baby's 6 months old. We strive for a longer amount of time, but if we can get our moms to this point, then that's definitely a huge success. Pediatric well visits are completed and vaccines are up to date. Education, employment life course goals are met at graduation. Birth spacing is one of our biggest benchmarks, and as Dr. Patel just talked about, we do follow up with contraception education. refer them to clinics who provide these free services and devices. And so that's been a huge success for the girls in our program. Next slide. All right, so here are some health statistics. Another thing we do is we perform GAD-7's PHQ-9 assessments for mental health well-being, as well as child ASQ screenings for milestone development. And I'd like to add, if there is a common gap that we've noticed with our clients, it's offering those mental health resources. That has been a challenge for us. And also transportation services in the more rural areas to get to their appointments. Next slide. So NFP provides the most current rates in reducing our maternal and child mortality risks on a national level. As you can see here, 35% fewer cases of gestational hypertension, 31% reduction in very close-spaced subsequent pregnancies, and an 18% decrease in preterm deliveries. Next slide, sorry. So in Texas, the maternal pre-pregnancy BMI has increased about 30.5% since 2010. And that significantly increases risk for GDM, PIH, and other health complications. Nurses provide education on lifestyle modifications, such as healthier eating during pregnancy and exercise, performing weight checks, blood pressure readings, any physical or health changes. These are all performed during each visit with the client. And the nurse is also responsible for reporting any concerns to the client's healthcare provider. And we have a motto, and that is only a small change is necessary. And so with that, NHV, nurse home visitors, can provide the encouragement and support clients may need to make those small changes and stick with them to get to the bigger outcome successes. Next slide. So another assessment nurses do is just reducing those environmental hazards as well. Currently, we're solely providing telehealth visits. So those have been a challenge to fully measure, but pre-COVID and possibly in the very, very near future, we will begin incorporating home visits again for our clients. So this area will be accurately assessed. Nurses capture any safety concerns in the home, in the neighborhood, any family partner support systems, and referrals to community resources can be utilized as needed. Next slide. So again, just to recap what the nurse and the client and the family partnership relationship is, I like to tie it all together. So we do focus on clients, but when we're in the home, we also are able to create relationships with the family members as well. And so that is that nurse home visitors practice targeted prevention efforts, promote healthier pregnancies and birth outcomes, utilize assessment skills to detect early warning signs of health problems, monitor for those health problems, and advocate for clients. Next slide. And so what about dads? That has been a topic recently. Nurses have also provided parenting guidance for dads during visits as well. Nurses invite dads. They allow them to be more inclusive, to join in on visits when they can, even scheduling around maybe dad's work time as well, maybe after 5 if needed. Making time during the visits to listen and answer any questions or concerns they might have, provide facilitators and education specifically for dads or involved partners, and promoting those positive male, healthy male role models for the child. So as you can see here on the slide, there's an invitation we have for our fatherhood celebration we are currently providing for our NFP dads. Typically we have client celebrations just for mom and for baby, but dads deserve some recognition too. So we have an ongoing gift pickup this week for them. And you can see the little picture there with an actual client this past week that has picked up his dad kit as well. And so we provided a matching daddy and child tool set. One is kid friendly, of course, toiletry bag, t-shirt, and other little goodies. So we're excited to know more about the RGV Dads program and how we can provide support for our dads as well. And that's...
Thank you, Gabby. Next, I'm going to focus specifically on some of the integration of the secondary data, the stakeholder needs identified, and the use of focus groups to learn a little bit more about what was needed. And we definitely see ourselves as a community academic partnership and continuing to work together. I know that Jeremy San Miguel is here from UTRGV. Thanks for joining us today. And a few others who throughout this process, we've continued that integration of projects and moving just in a direction where we can better serve the community. Dr. Patel did introduce a project, again, both the Hidalgo County and Smith County. The specific goal of the project was to address no prenatal care. And then some of the methods and strategies that she provided an overview for, I want to emphasize the use of secondary data, mapping, and targeting specific communities. To do this and to better understand what was happening in the specific zip codes communities, we completed some focus groups to learn about the needs of the community residents, moms, and then in our third year, actually, we met with dads and we started integrating a focus of addressing needs of dads. So this program specific process and reach was very important for us to assess. That's one of the reasons why the mobile unit continues to be funded and has been advanced for funding. We also have the integration of several of the key strategies that were identified into NFP practice. For example, Gabby noted the partnership in addressing dads' needs. NFP was critical in us being able to reach specific communities and for the focus groups to learn more from moms, from dads, and also how we can better serve the community. So some of the stakeholder discussions that we had, and these were attended by over 50 individuals representing Hidalgo County and Cameron County. UTRGV continues to host these, and all of us continue to be a part of these stakeholder discussions and how do we address maternal and child health in the RGV area. So some of the common themes across communities were the lack of engagement of family members, including grandparents and extended family in prenatal education and care, low prenatal education awareness, availability of education, but also awareness of the education, suboptimal utilization of NFP. So in many ways, we worked with NFP to how do we get the word out? How do we maximize the reach of NFP and enhance the understanding of the services that NFP can provide moms who are not only young moms, but also an older population that is first-time moms. And Gabby didn't mention the age range, but they have and serve moms who are first-time moms in their 30s, who may be late 30s, high risk, and other. There were also mention of weak relationships and low trust between medical providers. UTRGV was also new, and a lot of the clinics were new coming in, and it was also great opportunity to learn more about each other. We work very closely with pediatric Department of Peds as well as OBGYN to build those relationships and enhance community reach. Also fragmented health services and community resources, low cultural competency, cultural humility of providers was noted. lack of bidirectional communication between patients and providers and what ways or strategies could be used, the lack of father engagement in prenatal process, all the way from missing the clinic, not including dads on the wall, not including dads, images of dads in brochures, lack of investment and accountability by academic partners in the community was noted. Low health literacy of mothers and family members, need to integrate community health workers into existing services. I remember our first meeting, one of the key things that helped us as far as building the stakeholder meetings and serving the community was that our funder, the state, was always present as well at these stakeholder meetings, helping us determine linkages as well as other needs to education that existing state programming may not have been reaching and serving the community. Need to integrate community health workers, I mentioned that, the lack of mental and behavioral health services, the reach, and financial barriers. Specific to Hidalgo County was the lack of prenatal care resources for colonias, reaching to colonias and serving the specific, and again, this was in Hidalgo County. I know that we have the Community Action Board and members, and there's a lot going on through the UTHealth School of Public Health, Brownsville campus and partners. Barriers to the range of contraceptive options, and then the shortage of clinicians providing prenatal care and reproductive health education. So these were the specific areas, and we took the stakeholder information, then built up into our focus groups. As Dr. Patel mentioned, we were using the maps, the strategies, and saying, okay, this is the data. Then working in a very systematic way, partnering to then focus on, okay, what do stakeholders think about this data? Then we developed from those stakeholder conversations our discussion guides for the focus groups. We did find 4 overarching themes. These were stress and perceived discrimination, clinical and organizational level experiences, family and support, and fathers and their roles. We also had some emerging themes. There was some mention of these: child health and maternal mental health. The second round of focus groups, we did see where maternal mental health, and we're hoping that that's because sharing these with all of our stakeholders, I know that there was a lot of integration of activities and programming immediately so that those resources and needs were addressed. And we saw in time 2 of our focus groups where maternal and mental health was not as significantly mentioned and was seen as supported in the community. So around stress, there were 2 primary reasons for a delay of initial prenatal care appointment setting that were identified. One was the lack of insurance or method for payment. We also found that there were specific clinics or organizations. There was a lack of information at the clinic level and knowledge of payment for Medicaid. So we wanted to make sure that that was taken care of through grand rounds, through other information to providers in the community of when payment and enrollment was available for moms. We also looked at clinic infrastructure and preference to delay initial prenatal care appointment to 13 weeks. So while we were seen as a barrier or a challenge to get women in early, it was also a preference in the community to delay. So we had to work around that and explain that. So this is one quote that we have that refers to the stress and perceived discrimination. I want to get care now, but there's a list of doctors and I'm like, okay, I don't even know. I had never seen an OB-GYN before. So I was like, I don't know what the first thing is. I don't have insurance. So I had to go through the process of getting Medicaid for pregnant women because my job didn't offer insurance. That was a little bit difficult, trying to get all my information with Medicaid, and giving them everything and then trying to get seen. I think I was seen 4 or 5 weeks after the first time I was trying to get it. So a delay specific in process that a community health worker, in looking at these findings and the information, would then provide information, tailored communication to respond to women regarding the delay or advising them on other resources to improve accessibility. So clinical and organizational level as well, and the slides will be available to you. So I do want to leave time for our panel as well as discussion. So also with family and support, specifically to our border region, no, it's because we're on the border, so family, they were talking about their family, come with all that culture, beliefs, values. Sometimes they don't even ask, they just do it, or they tell you to do it. You're like, okay. So the looking at dynamics within a household culture of grandmas or moms wanting their daughters to look at and attend to prenatal care needs the way that they did. And perhaps integrating alternative medicine and other, which caused tension within the house, as well as understanding and shifting of understanding. And I think Jesus will also point to a few cultural and machismo and other issues that have been integrated into our community and may impact or stereotype. Also fathers and their roles, and then how we tailored the programming. So with Nurse Family Partnership, the tailored recruitment to those targeted zip codes, using the data that we had related to the mapping and the needs, we then looked at how can we recruit, coordinate, and expand the program to serve those women. Cultural humility and competency, UTRGV then began focusing on grand rounds, patient-provider communication, looking at front door to next appointment to delivery practices that could be integrated. CHWs, again, Jeremy's here. I don't know if Celia and Maria are, but great, amazing job and integration and reach into the community that really addressing some of those education needs as well as understanding of navigation of programs that are in existence but may not be used. Increased focus to promote educational opportunities for fathers. There's been the integration of fathers. Jeremy San Miguel was hired as one of the first community health workers, male community health workers, to address this need. He continues to work with UTRGV through PEDS as well as OB-GYN and group and individual education for moms. There was an application for centering pregnancy from this work, and centering pregnancy as part of the pediatric department at this time. So we really worked at connecting voices with programming, and I think that that's one of the unique aspects of the Brownsville campus. And as we celebrate 20th anniversary, those processes and methods and strategies of integrating multiple methods, data, the cohort study, other data that is available, and using that to inform our practices, as well as integrating stakeholders and community partners in deciding how do we work together to address health in the Rio Grande Valley. So that's one of the most amazing things in this campus, and something that I look forward to continuing to address and follow that lead of Dr. McCormick, Dr. Reininger, Dr. Fisher-Hawk, and all of my other colleagues here. So some key activities in Hidalgo County. We looked at the Built Community Academic Partnership. UTRGV continues to organize quarterly stakeholder meetings and engagement. We partnered with UTRGV OB-GYN to develop the mobile clinic. The mobile clinic has now been funded for a second year by the state, so that's sustainability and continuity. But we integrated some key evaluation strategies. So the program evaluation was necessary for the state to see the value, the reach, so integration of those partnerships, but with key metrics. Enhanced linkages to services and referrals. That continues to happen. The CHWs are working with NFP and targeting referrals. We also helped with piloting lifestyle medicine, and that continues to get integrated into the pediatric department and clinics, and educated providers on LARC, NFP, and other. So ongoing grand rounds and education to providers in the community. So these are some of the key activities that continue to take place as part of Healthy Families in the Rio Grande Valley, and hoping to expand some of these to Cameron County in the future. Okay, I am going to pass it to Mr. Peña and Jesus. Thank you for joining us. Last but not least.
Thank you. So, statement of RGV Dads is to create opportunities for fathers in the Rio Grande Valley to network through meetups, blogs, vlogs, and sharing about fatherhood. So my name is Jesus Tomas Peña. Thank you for the introduction earlier. So back when my first child was born in 2009, I found limited resources. YouTube started in 2005, so it was still in its infancy, and I could Google some things, but I was looking for more. So upon researching, I found what is more deemed like a franchise called City Dads Group. It's nationwide. They did have some groups, but only in Austin, Dallas, and Houston at that time. So anything south of Austin, any group for dads just simply didn't exist. I also found Fatherhood is Lit, which is run by James Lopez, and he's based out of Staten Island, New York. And then I found a gentleman in Los Angeles. His name is Dwayne Richards, and he has and still continues daddy doing work. The first group, City Dads Group, is started by two gentlemen, Lance and Matt, and they're all still going strong. But it provided a model for me, and I did reach out to City Dads Group at that time and gave them statistics about the Rio Grande Valley. Unfortunately, at that time, we didn't fit what they were looking for, but I do want everybody to now currently know that now they are interested because they're seeing the works that RGV Dad is doing in the community. So this started back in July of 2018. I was just at a crossroads. I wanted to not only help myself and my family, but I wanted to help others. So I could wait for a group like City Dads Group to come here, or I could just get to work. And so, anybody that knows me, they know that I'm ready to get to work. So some of our meetups happen at local libraries. Our libraries in McAllen and Edinburgh are just wonderful centers for engagement for families. And so we did crafts in the summer and participated in their reading programs. They're just great opportunities at local libraries. Over time, I began to develop relationships with entities like RGV FC Toro soccer team. And what I wanted to note there was that Gabriela Calzada helped with our first RGV Dads takeover in 2019. And then most recently, Savannah McVoy in 2021 with the Father's Day outing. There's a gap year, obviously, because of the COVID time. But what struck me most about these two wonderful women were that they really picked my brain about what fathers wanted to do with their children at these events. So I can tell you that even down to the craft that we did back in 2019, we helped develop that craft with the help of Lakeshore Learning in McAllen. And so much so was it special to a dad that he came to the 2019 and to the 2021 Father's Day outing, and he told me over the phone, I still have that craft mounted in our master bedroom. And that just really touched my heart that we're definitely doing things that are meaningful for our dads. We've also coordinated with the Vipers in basketball. Connecting with the university is very important to me. And so I've developed some relationships with UTRGV athletics. We've been to men's and women's basketball games together. We've seen men's baseball from the presidential suite, which is a very nice opportunity. We went to Chick-fil-A and Lego. Chick-fil-A offers different events, slime events, making slime with the children, or mini builds at the Lego store. One of the ones that I really liked was with the Home Depot. So the Home Depot was providing a monthly build with our children and anybody that wanted to go. And so we were inviting dads to do that every single month. it just provided an opportunity for us to always get together on a regular basis, which was really important to me. Unfortunately, that event continues to be on pause, but we will be getting back to that soon, we hope.
And Jesus, I
Yes.
don't mean to interrupt, but as you're talking about the blog, can you talk a little bit about why you started? I mean, you shared that with us, and whatever you feel comfortable with sharing.
Yeah.
So what you were missing for dad.
Yeah, so absolutely. The and it's great. I know that there's a bunch of great work being done in the local community, but the delivery of the information, it does, I'm going to use the younger generation's slang here. It hits different when it comes from a male and when it comes from whether it's written language like this blog here, or whether it's in a format like this, which I'm about to get to. And then definitely it hits different in person. And so I can tell you regarding the blog, I did want something that men could read, because back in 2009, I was searching for things to read and I was finding them, and it was great, but they were from, a different perspective of the country. And so I wanted it to be something local. And so I began sharing things like when we went to the slime event at Chick-fil-A, or how to choose a daycare. And I did what's called crowdsourcing. So I would talk to dads or talk to some of the moms who are interested in offering their input. And so I took all that information and wrote a daycare blog post. Back to school is another big thing that we have to help our families with. The RGV Dads takeover, like I mentioned, and even protesting property taxes, or how to get the best deal if you want to take your children to the Gladys Porter Zoo in Brownsville, Texas. And so I did put a couple statistics on there to show you that this is not just me and a small group of people reading this. There are thankfully thousands of people viewing the blog, and there's a link there at the bottom for anybody that wants to access that. Another thing that we're starting to delve into, but we haven't fully explored, is called a vlog, which is just a video blog. We started doing what was called Tony's Fatherhood Experience. And so there were a couple of episodes that we did. And again, you can see one of them had over 100 views and great analytics when I studied that. There's a link to the YouTube there. One of the things that I wanted to share was that, and this was mentioned earlier, that Tony was sitting right next to his wife at an appointment. They were asking questions about the father, and sometimes they were simple questions like father's name, father's date of birth, and he couldn't help but wonder, why aren't they asking me this? I'm sitting right next to my wife. And so these are some of the things that we would like to be involved in, of course, with the permission of the medical professionals, and maybe just sitting and meeting with their staff and talking about, we've been excluded and we would just love to be included and recognized. I know somebody mentioned earlier about even just having wall art of dad with child, or dad with the family, or something just more conducive to fatherhood would be a welcome sight. We are on social media, so you can find us on Instagram, Facebook, Twitter, and YouTube. Facebook seems to be the most popular way to follow. These numbers are fairly current as of the beginning of the week. So you can see that Facebook has over almost 600 followers. And I try to make sure to keep the information fresh. So if you were to go to one of these sites, you would see at least 3 posts per week, more than likely more. I think that's very important, especially considering the younger generation. You never want to go to some place and find stale information, because then and the likelihood of you returning is very small at that point, because if they're not keeping up with it, why go back? And so I do strive to keep up with that. As far as sponsorships, I'm thankful that a lot of people in the community have welcomed us with open arms. And so we had a financial institution in McAllen help us print some shirts. We've even put together some dad's baskets with the help of Children's Orchard in McAllen, and also with the Healthy Families Initiative with Jeremy San Miguel and other folks. We've even donated to others. And Nurse Family Partnership, just recently, like was mentioned a moment ago, we put together some shirts together to give out to dad, an informational postcard, and then we talked about giving them a book, well, like a child's book. Some other collaborations, one of the most intriguing to me, and where I met Dr. Melissa Valerio, I believe, was at a dad's focus group back in September of 2019. And again, it was just so striking to me how just the thoughtful questions that were being asked, and then the listening ear that they gave all of us. I think it made all of us just feel really valued at that time, and also feel like we're trying to, the things that we're sharing are going to produce change moving forward. I've mentioned before about Jeremy San Miguel and Dr. Cynthia Gonzalez. They helped what's called Dad's Mental Health at the UT Psychology Clinic. That's something that I'm about to speak to in a slide coming up, but very instrumental to partnership with the university. Beyond the RGV, I've even talked to Mike Mackert there at UT Austin. I know some of you know him. They developed the Fatherhood Playbook app. And so a platform like Twitter really lends itself well for myself to connect with others outside of the UT RGV area and just expand and continue to collaborate. In Cameron County, because I do live in Hidalgo County, but I am from Cameron County, there is that idea that I want to continue to expand west and east of this county to help other dads. And so with Victor Rivera and the United Way, we helped with his Bright by Text, and also he distributed flyers about RGV Dads in Cameron County. So very thankful for that partnership. Some of the Dad's Night Out that we've done, so this is without children, we've gone to Top Golf, we've gone to 5x5 Brewery in Mission, and then upon having the COVID situation, we had to pivot, and so we went towards Zoom, and I'm very happy that you can see a snip there, a picture of the dads that are engaged in a meeting together. And so thankfully we have pretty good turnouts, and we have a variety of questions that we would go through. Let me see. So Dr. Valerio doesn't have this slide, but I just wanted to give you an idea of some of the questions and how they come about. So over time, I empowered another dad named Victor Rivera to curate some questions. And so generally, when you come to a Zoom meeting with us every Thursday at 8 p.m., there are going to be 3 questions. So we're going to center our discussion around 3 questions, and they're timed. So 8:10 is when the first question drops, then 8:20, 8:30, and then last at 8:40, we do what's called Dad Advice, where a dad can ask any type of question he wants to ask. Anything we've had these questions, anything from a diaper blowout to where can I take my wife out for a nice dinner? So some of the questions that we recently went through were like, in hindsight, is there a time you didn't stand up for someone or something but wish you did? What were some of your biggest insecurities when you were in high school? When you think about a fork in the road in your life, what was it and why did you choose that particular path? So Victor has been doing a great job curating these questions. Dr. Valerio mentioned earlier about the culture and machismo, and you can definitely see that these are questions that are very thought-provoking. You're not going to get by with yes, no, 5, 10, 15, 20, So I'm very thankful that some of the guys, they do acknowledge that perhaps one generation ago, their dad would never speak about these types of things. You would, not even to their own son, and not to their peers. And so it's very nice that these gentlemen are willing to step up and speak to some of these questions. And not only that, Dr. Valerio, but I've even had these men that could not be present. They send me emails and apologize for not being able to make it to the meeting. And that always strikes me because it shows their commitment to the group and their involvement. Involvement so far as that some of the dads that can't make it send me their responses and specifically ask me to share them during the meeting. And I want all of you to know that I do follow through with that, because if it's important to them, it's important to me, it's important to the group. So now I think I'll be on with the next slide, which is a quote from Joe. So this was back in 2019, December. Here's what he said. Probably the lack of sleep and tension in the relationship. I know it's common and that it gets better, but still rough when you're going through it. Paternal postpartum depression is not really addressed as a thing. You leave the hospital with like 10 appointments for mom and baby, and the father is expected to just wing it. It's fine and we're pulling through, but I wish they had one person come by the postpartum wing to talk to dad and explain that, hey, you're in for a rocky ride for a bit, but it's normal. Stay strong, you'll be okay. But it's not really offered. So Joe actually sent this to me through a Facebook message back in 2019, and I was just captivated by this. I was disappointed, my heart went out to him, and I just said to myself, this has to change. I can't sit here and do nothing. So the next slide is, thankfully about 2 months later, because things take time, I coordinated with Jeremy San Miguel and he reached out to Dr. Cavazos and we met at UTRGV Psychology Clinic and had an in-person, for probably the best way to frame this as a support group. We sat, we talked, we went to Wingstop afterwards, which is really nice too. And then as everybody knows, if you look at the timeline, the very next month is when COVID started here in our area. So that's when we pivoted to Zoom. But I was very thankful that with the help of UTRGV, we were able to get this going. Another thing important to note about the group of dads is that it's diverse. So we obviously have Hispanic because that's the common ethnic group in the area. But we also have white fathers, black fathers. Some of the fathers are single, some are married. Some of the fathers consider themselves a bit older. We've even had a dad come in because he was interested in starting the process of fostering, so adopting a child. And then also our fathers are sometimes fathers to not only their children, but also to stepchildren. And so it's always wonderful to hear about vacation plans coming up or different activities that they're doing day in and day out to continue to build those relationships with not just their children, but their stepchildren. So other things besides the 3 questions that come up that I have felt are very profound deal with some of the dads referencing marital issues. So sometimes they talk about things that are strange to their relationship. Sometimes we talk about things about like emotion and how to deal with stressors. Sometimes it's sexual in nature, and we discussed that as well. I had a dad talk to me at the 5x5 brewery event. Upon walking in the door, he said to me that he was glad that he found a support group. And at that time, I hadn't really thought of RGV Dads as a support group. But when he said that to me, it just really caught my attention. And so he was in a situation where he was in the area doing graduate work at UTRGV in social work, and he's about 300 miles away from his child, and he's just looking for support while he's in the area and also while he's on his fatherhood journey, and again, just kind of distance from his child. So I thank you guys for hearing the presentation about RGV Dads, and I look forward to any questions.
Thanks, everyone. I think what I'm going to do is go back to this slide, or we can turn the slides off and go through some questions. So any or comments?
So Melissa, inevitably, I have comments and questions, so that won't surprise
We
you.
love your comments and questions, Dr. McCormick, and there is so much, that we can comment about. And I know that you've explored different relationships with a cohort and other, so look forward to your question.
So I wanted to thank Mr. Peña for that presentation and his work. It's quite important. I wonder, just a question, Mr. Peña, how much you can dwell on health of the men, because I'll give you some examples. We have this large cohort that we've been studying now for many years in Cameron County, but we know the data from that look the same in Hidalgo County and Starr County and Webb County and everywhere else. And that is that that young men already between the ages of 18 and 35, 50% of them are obese and 17% already have diabetes. and many of them already have prediabetes. And this sets them up, obviously, for very significant health issues. And I wonder in your discussions and all the great things you're doing, whether you have the opportunity to discuss men's health. And I get it, mental health is clearly very important, and I'm not dismissing that, but these other issues we have learned are really very, very big. And I just wonder if you have had the opportunity to introduce that into some of your the various things you're doing.
Absolutely. So yes, that is something that we talk about. We talk about our physical health. So some of us say, I'm go to this gym. I'm a member of Fit Lab, or I'm a member of Orange Theory Fitness, or let's go on a bike ride together. These are things that are very important. So if you were to go to the Instagram, for example, and look at the stories, you would see me even biking with my children. So we're always talking about things, not just necessarily like I can do for myself, but also how can I be healthy and how can I include my family in that process? Because really, we all need that. And that was extremely important at the beginning of the pandemic because options were limited and we weren't quite sure how to navigate how far we go from our home. So one of the safest options was I'm going to bike, and I'm going to bike in my neighborhood. And I feel like that's safe. I'm getting exercise, they're getting exercise, which also does help our mental health.
And Sylvia and Gabby, I don't know if you want to that response, but I know one of the key things that the community partners have identified is free resources or free things to do, low cost, then also providing that, Dr. McCormick, as options in the community.
So Melissa, I have a couple of other questions. Actually, I have a whole bunch, but I won't take up everybody's time. I know that Dr. Patel said that you looked at death certificates and birth certificates and those kinds of things, but I didn't see, and it's always, one of the things that always happens with infant mortality, and I've worked a lot with infant mortality, and particularly in developing countries, a place like Pakistan has infant mortality rates up in the over 100 per 1,000 births, for example. So I'm pretty familiar with this issue. It's a huge one. What I didn't hear was the cause of death of these kids. And I think often we have a reflex to say, well, it's prenatal care. Yes and no. Prenatal care does have a big impact, no doubt about it, particularly prenatal care in later part of the pregnancy, because that's when you start to see things like eclampsia. That's when you start to pick up low birth and intrauterine growth retardation. Those are huge risk factors for infant mortality. Also, I didn't see, for example, age, since we're talking about infant mortality, talking about mortality over the year after birth. Well, there's a lot that happens during that time, and it's very important to look at the age of that, and things like the educational level of mothers, which is very important and well known to be an important factor. So I wonder about all of this, because when you go out to actually educate people, it seems to me that knowing what you're educating them about, that is some of the key causes of death, is really important. No question that prenatal care and all the things that I've seen here to do that are really important, because that builds the fabric of the community. But also to focus on causes of death. I happened to be in a presentation about, I don't know, 2 or 3 years ago when David Lakey presented some of this information early on. But I still don't see the cause of death and how that fits into this overall picture.
Yeah, those are really great comments, Dr. McCormick. And I just want to mention, we did work with Dr. McCormick and his team early on in Healthy Families on some targeted projects, so that was a great opportunity for us to connect with his team as well. So a couple of things that you brought up. So when we looked at the cause of death for the infant deaths, it was as expected. The predominant cause was congenital malformation, so birth defects. So that came out very clearly. That was something that we compared it also to Texas overall and to the country, and it was very similar in the top 5 causes of death, kind of lined up with what we see nationwide. I think to your comment about the prenatal care, that's very valid. What my sense is that prenatal care gives an opportunity to link with other health ongoing issues that may or may not have been either detected or managed. So we talk a lot about the pre-pregnancy obesity, hypertension, diabetes, a lot of the chronic conditions that for many reasons, just getting care for those things and even being identified early enough are not accessible to many people because of either, lack of awareness or one of the major causes is just lack of healthcare coverage to be able to be seen. If you're deciding between, I want to buy groceries this week or I want to go get, a preventive care visit, oftentimes the decision is, it's a tough one, but you might opt for the groceries that week, so there's a lot of factors that go into it. But I think, improving access to prenatal care is a window. It's an opportunity to get women connected with services that they may need and not have otherwise had access to. Another thing, just a comment about pregnancy is that it's a unique time in that women tend to be motivated to change behavior during pregnancy. We don't see that in the Valley as much, but in our Northeast Texas population, there's a pretty substantial maternal smoking rate with, 9% of pregnant moms smoking. And if you think about, you can help people stop smoking, quit smoking, and they may quit, but they may start again. But we have noticed pregnancy is a very critical window in that women and families are motivated to make changes during that time that they might not have otherwise made. So sometimes using the opportunity of prenatal care as just what exactly it is, an opportunity to connect, to educate, provide resources, all of that may be something that in itself is valuable outside of what you provide in the prenatal care. Measuring someone's circumference and those things may or may not be that important, but you connect on many different things. So that's what we're seeing it as. So I do appreciate all Dr. McCormick. We've had this conversation many times, and I really do appreciate the insights that you bring and your experience, especially in other parts of the world.
So Dr. Patel, you've actually said something which I find very interesting and wonder why there's not more research on it. If the major cause is congenital malformations, who is looking into this? And for example, we know that there are underlying conditions in our population, especially in pregnant women, that are conducive to more congenital malformations. Smoking is definitely one of them. Any alcohol consumption is also, but also obesity and gestational diabetes, all of it, and even hypertension, because hypertension is so important in terms of intrauterine growth retardation and also eclampsia. I don't know how much, I have a feeling there is a fair amount of eclampsia here. Obviously, that's a little bit more risky for the mother sometimes than it is the child, but these are all issues also. And educating people about these is, and targeting that is also, I think, as in the middle of, or as part of what you're already doing, I think it is also very important, because a lot of people wouldn't be aware, for example, that obesity has a modest effect on birth defects. And I wonder how many of these birth defects are repairable. And is it a fact, is it just that women are not, that the babies are not being seen? Because I in my pediatric training, I trained with Dr. Chick Coop at Children's Hospital in Philadelphia, one of the great surgeons for repairing all kinds of things. So I know that so many of these things are fixable, but I also understand that the lack of access to healthcare in this community.
Absolutely. Good points.
So is anybody looking
I
at?
think, Joe, one of the things that you're pointing to is the opportunity to look and partner. I'm not aware of anyone looking at that. I Dr. Lee and I have been talking about, looking further into some of the data and working together. So definitely aware of anyone from OB-GYN or PEDS looking into it, but we can reach out to them.
So Melissa, we also have a faculty member in Houston who is extremely interested in this kind of thing. And if this is a cluster of birth defects, somebody should be looking into this.
Definitely opportunities for us and to think about for the future. So I know Dr. Lee's taking notes. I see her writing. So I'm sure she and I will get together soon.
Hi everyone. So I just want to just thank the whole panel that presented today. I have a question for Dr. Patel. You mentioned that you did evidence-based interventions with I'm guessing with the population down here in the valley. And did you consider doing like, I guess, did you think about like an approach of family strength perspectives? Since a lot of I guess the sample size of the population here is pretty. I mean, they might not be scared to go get treatment at a facility, but they're more inclined to be comfortable doing treatment with the community or family, or like, I guess the culture just being like, I guess with curanderos or like just more home remedies. Do you consider that, or do you just go based off like just I guess the evidence interventions, as far as like, I guess the broad part of like the whole nation? Or do you think of like the population here, like in the valley?
That is such a great question. I'm so glad you brought it up. It's definitely something I've thought a lot about as well. First off, thank you. First off, I wanted to mention that we had some limits on us because of the funding source, that it was funded by the state. So we had to kind of many of the things that we focused on were things that they would help support, and they were very much clinically oriented services. But one thing that I've been doing work in the area of community-based doulas and other types of, we call them lay health workers, but that's I think a disservice, because they come with such important skills, insights into the community, into traditions, into culture. So calling someone a lay, I think that's just doing a little bit of, that's minimizing the impact and the knowledge and the experience they bring. So we are working on some projects where we're looking, and that's not in the valley yet, but we're doing a project here in Central Texas to look at the impact of community-based doulas and how they can support moms and families as they're going through the birth experience, with a specific focus on postpartum. So many of the things that Gabby brought up, that Jesus brought up with a postpartum, both for the moms and the dads, looking at ways to support families through a little bit less clinical, less in the hospital and in the clinic, but more, how can you take the supports that a person has in their network and in their home, in their families, and work with that within that structure to support so that the outcomes are different or better. So yeah, I really do appreciate that comment. I think that you're very much right on. It's something that we'd like to work and maybe develop a little bit more now that we've learned a lot more about the community, have looked at the focus group data, the other data that we've have had access to. It really points to the need for kind of looking at things outside of just the clinic setting. So I do appreciate that. And I took some notes, and Melissa, I don't know if you've got some additional, insights from the community.
I think there's others also on the call today that have some input. I think it all depends. The community health workers, I think, by experience, are more likely to be asked about questions such as alternative medicine or any of the other types of curanderos, healers. There is limited research in alternative medicine and prenatal care at this point that's out there and written about. But I think that there are ways to integrate some practices that are safe. I mean, first is safety and outcomes. And when we talk about evidence-based interventions, those are those that have been studied, looked at, and are appropriately a safe practice. So I think, is it used? Yes. I think there's a lot more work to be done in that area. And Sylvia, I don't know if you have any experiences, and Gabby, as nurses, in serving the community, questions that have come up that you can share. But right now, if the focus is on evidence-based interventions, we understand that those questions come up, but that may not necessarily be the first thing we address. We respectfully listen and look at and integrate some of those, but a physician and MD is integrated. Sylvia and Gabby?
Yeah, so I was going to chime in a little earlier after Dr. McCormick addressed the infancy mortality rate for infants. So this is kind of piggybacking with the last comment that question that Jeremy just asked. So part of, as a nurse home visitor, again, we do get asked questions, just cultural practices, and just as a nurse maintaining that cultural sensitivity for the client. And like Dr. Valerio just stated, making sure those are safe. And then of course, referring to the OB just to kind of compare and, with the treatment that they're under. And then going back to the infancy mortality rates, although this isn't in a congenital form, but the nurses do go over safe sleep and addressing SIDS with the NFP clients. Unfortunately, it's not a community-wide thing. It's just, particularly for our clients. But every visit, there's a continuous assessment. Are you putting your baby on to sleep on his or her back, or are there blankets? And so just providing that teaching and safe sleep areas and risk for sudden infant death syndrome. And I just wanted to kind of point that out.
From a community standpoint, I think that it's important to understand that medical health professionals, public health professionals are also competing against social media and deeply rooted ideas and information that we are trying very diligently to respect and honor and find the root of some of those trains of thought, and then work with them within what is comfortable for them. So like Reyes said, we're looking at that family strength perspective. We're looking at building on the knowledge that they already have and empowering them with more knowledge so that these beliefs can maybe turn into ideas that are a little bit more flexible and not as plastic, right? And I think that's where the nurse home visitors come in, and nurses in general being trusted members of the community going into the home and allowing them to ask some questions that they may not feel very comfortable asking their physician in a clinical setting, or they may already feel judged from the moment they walk into that clinic, both mom and dad. And so that is a really important aspect of nurse family partnerships practice, is building that community and understanding with the family, and then working from there. And like Gabby said, it's incremental changes that we're looking at. We're not looking at completely changing a 180 shift in their perspective and knowledge and ideas, but that incremental seed planting change that we can make is what we find most impactful.
So this is Belinda Reiniger, and you know, this has been just such a tremendous discussion and rich presentation, highlighting how community partners and our campus and university have come together to address an important issue. And I do hate to cut it off, but I know that probably all of you have meetings that are now stacking up, and so I don't want to do that to you either. You know, I commend you all. I appreciate that you've taken so much time to be part of our 20th anniversary celebration, and I think all of us really got a wonderful sense of how you've used mixed methods to create partnerships. You've created very strategic intervention approaches. You've got this multi-level intervention approach. So just, you know, a lot of really best practice. And the way you all collaborate and communicate was really wonderful. So you can see lots of applause. I'll give you a live applause. Congratulations. And thank you all so much for your time. There you go. Cheers, right? So we've got it going on here. Thank you all, and I wish you all the very best. Thank you so much.
Thanks, everybody.
Thank you.
so much.